Hello, we're Group 4 with Brittany, Ryan, Brooke, Clifford, and myself, Eddie. Our case was about an 83-year-old man named Mr. Perry whose health has deteriorated recently. He has an internal defibrillator and a pacemaker, but states he feels his body is all worn out, and he wants both to be deactivated. The defibrillator has been stopped, but when his doctor warns that stopping the pacemaker will likely end up with him dying in a few minutes, Mr. Perry states that he knows and he's done fighting. Our team of nurse practitioners and social workers have been called in for consultation.
Hi, this is Ryan with the Masters of Social Work program. I'll be talking a little bit about ethical and legal overview as it relates to Mr. Perry. We do not see an ethical concern, but we will ensure consultation happens between a mental health professional and Mr. Perry. The patient has the right to make such decisions. No, we don't take his request lightly, and we would want to make sure he fully understands the repercussions of turning off the pacemaker. We are concerned that he is making this decision in extremes. Instead of an ethics consult, we believe the patient would benefit more from a palliative care and hospice consult and mental health professional assessment. Mr. Perry is making an informed decision after speaking to his cardiologist. The information should be reiterated to him when possible. It would be important for Mr. Perry to consult with a member of the team and how end of life impacts individuals. His decision to end his life may impact his supports. The patient has received no medication that would impair his judgment, and he has no other signs that would make us concerned of his decision-making abilities. This patient may have a provisional major depressive disorder episode diagnosis or suicidality rating that the team should further explore. This would impact his decision-making ability. There are two ways to identify competence. The individual can make all decision for oneself. The second is combined clinician assessment and the legal determination by a judge. After assessing, it may be appropriate to explore this legally depending on the outcome of the assessments. The patient is consumed to have the capacity to make decisions until proven otherwise. We do not believe that an ethics consult is needed at this time. We would highly recommend a palliative care consult and hospice consult, and like I mentioned before, a mental health professional assessment in order to explore the patient's needs, wants, desires in regards to his medical and quality of life plan. If there is continued concern that the patient is not able to make this decision or it is unethical, it is not the questions to get a consult and even consult risk management.
Hi, my name is Brooke Martin. I am an MSW student and will be talking about the ethical principles involved in this case. The NASW Code of Ethics identifies 6 principles which are based on social work's core values. The objective of these principles are to set forth ideals to which all social workers should aspire. With that in mind, there are 2 principles in particular which should be considered in Mr. Perry's case. The first is the ethical principle of social workers respect the inherent dignity and worth of the person. Here, it educates that social workers promote client socially responsible self-determination, as well as seek to enhance clients' capacity and opportunity to change and address their own needs. In Mr. Perry's case, respecting his right to self-determination when making an informed decision about his medical care is important. We then look at the ethical principle of social workers behave in a trustworthy manner. A key point in this principle is where it educates in regard to acting honestly and responsibly and promoting ethical practices on the part of the organizations with which they are affiliated. Unless it is determined that Mr. Perry's emotional or cognitive functioning is compromised, we believe that our suggestion to obtain a palliative care and hospice consult to explore his needs, wants, and desires in regard to his medical and quality of life plan is both appropriate and promotes ethical practices justly. We will now be exploring how the National Association of Social Workers and American Nurses Association Code of Ethics apply in this scenario. We are able to see that one commonality between the two is respecting client autonomy. Ethical Standard 1.02 of the NASW Code suggests that we hold an ethical responsibility to our clients in which we respect and promote their right to self-determination and assist in their efforts to identify and clarify their goals. This ethical responsibility may be limited, however, if the actions of the client pose risk to themselves or others. Similarly, the ANA Code of Ethics reminds us that the nurse's primary commitment is to their patient. In Mr. Perry's case, this would indicate that respecting his wishes to discontinue his pacemaker is most ethical. Other provisions of the ANA Code of Ethics also apply to this case. It is important to the profession of nursing to respect patients' autonomy and rights in determining care themselves. We must continue to advocate for our patients' needs, wants, desires, and well-being. Next, Clifford will be sharing relevant laws and regulations that we feel should be considered in Mr. Perry's case.
Hi, my name is Clifford Moore. I'm one of the AGMP nursing students, and I'm going to tell you a little bit more about relevant laws and regulations. The Patient Self-Determination Act, passed in 1990, requires all healthcare agencies to inform all adult patients of their right to accept or refuse medical treatment. Physician or technician-assisted suicide is another question. According to the 1997 case Vaco versus Quill, a doctor who assists a suicide must necessarily and indubitably intend primarily that the patient be made dead. In Mr. Perry's case, we wish to respect his wishes. Our end goal is not his death, but to give him the autonomy he deserves to make an informed decision to stop life-sustaining treatment. We will need to also check his decision-making capacity, but he has the right to refuse, and the legal aspects of right to refuse may vary state by state, which would make it important to consult your risk management team and even your ethics team. Key medical concerns include the patient is 100% pacemaker dependent. So if we turn off his pacemaker functionality, that means he will essentially have no heartbeat. So we need to make sure that he fully understands what's happening. Then we need to further assess his goals of care, which is a discussion that we could have with this care team. And then we need to establish, after having that discussion, is he interested in hospice versus inpatient comfort care?
This is Eddie again. There were a few key psychosocial concerns that we noted. First, his statement of being tired of fighting could indicate that Mr. Perry is depressed and possibly at risk for suicide. Also, there is a risk for social isolation as he lives independently and doesn't want to go to a facility. So we need to evaluate his mental capacity to make end-of-life decisions, as well as try to identify any friends, family, or loved ones that he may want present to help him with decision-making before we refer him to palliative care and hospice.
In formulating a plan of care, we need to establish the patient's level of competency and decision-making capacity with possible psychiatric consultation through education done by the critical care team, including palliative care. It's important to confirm that he does want to be a do not resuscitate patient. Confirm his wishes once again. Really want to make sure that he understands and clarify any questions he may or may not have. Obtain informed consent for pacemaker deactivation. Make sure that we're there to provide patient and caregiver support in the event of deactivation, and then supportive care during and after pacemaker deactivation, which might include medications for comfort or just being there to support the patient and family themselves.
Hello everyone, my name is Brittany McCopes. I'm one of the AGNP students, and I'll be speaking to you about the plan of care, specifically the interventions needed for this patient. The first thing that we're going to do for this patient is we're going to assess them frequently for any kind of pain, shortness of breath, and anxiety that they may be feeling in the setting of end-of-life care. We want to make sure that if they are having any kind of pain, we are providing medications such as morphine. If they're having anxiety, we're providing Ativan or any kind of anti-anxiety medications, as well as supportive oxygen therapy, as shortening levels of oxygen for a patient can make them feel increasingly anxious, and we want to prevent that as much as possible. We'd also like to make sure that this patient has all of his needs taken care of. These may include spiritual needs, psychological needs, and psychosocial needs, such as having family support. And we want to make sure that we keep this patient as comfortable as possible overall. So for this patient, in terms of interventions, our plan of care is going to be as follows. First, we're going to interview the patient and make sure that we have the appropriate clinical team present with us. This includes a cardiology consult, psychiatry consult, social worker, registered nurse that will be caring for the patient, attending physician, nurse practitioner, and anybody else who's going to be participating in this patient's care, including a palliative care team. We'd also like to assess the patient's perception of his current health state and understand what his health goals are. We'd like to share knowledge with the patient of his prognosis as well as what it means to remove any kind of life-supporting measures. In this case, that would be the pacemaker. We'd also like to prepare DNR and make sure that the patient completely understands what a DNR is and the permanency that will result from a DNR. We'd like to obtain appropriate staff that will be involved in deactivating the pacemaker if this is what the patient decides to go forward with. And we'd also like to order the appropriate medications for this patient, including anti-anxiety medications, pain medications, oxygen therapy, and any other medications or therapies that we see fit for this patient. For this patient's plan of care, we are going to be using Dorothea Orum's self-care theory to drive our plan of care. This theory states that people are responsible for their own care and that people are distinct individuals. As such, we must always create care plans that are ever evolving and changing, just like our patients, and we must create care plans that are not cookie cutter. In this case, we will create a care plan that is to this individual's liking as well as to their healthcare needs. We'll make sure that we address all of his needs and make sure that we are providing care that is tailored to his exact wishes. As long as a patient is alert and oriented, we must do our best to ensure that we are providing care that is as distinct as the individual that we are serving.
Hello again, this is Ryan with the social work program. I'm going to discuss briefly a little bit about social work interventions and plan of care for Mr. Perry. This team would benefit from collecting data by performing a thorough psychosocial assessment interview or mental health assessment. A PQ-9, MoCA, and Columbia Severe Suicide Rating Scale would be conducted as a part of this interview. The PQ-9 would explore depressive symptoms with Mr. Perry. The MoCA will examine cognitive ability and function. And the CSSRS, the Columbia scale, will provide the team with a suicidality rating. In elderly patients, depression looks a lot like grief, and grief a lot like depression. After completing the preliminary assessments described above, the social work practitioner may need to provide a referral to a psychologist or a neuropsychologist to gain more information and decide if there's more going on than what fits their scope of practice. The social worker should then, in a separate section, introduce this client to some grief and loss psychoeducational material and specifically review the stages of grief and loss and possibly the change model. The social worker should make it a goal to help this patient understand that his role of life is changing and help him select a new role for these last moments of life. The social worker should also explore with him the grief stages and help him understand his identity shifting that will trigger feelings of grief. If family supports have been identified through the assessment interview, a family session to help bridge information from patient to family and family to patient, led by the social worker, would be very important. This would help inform the patient's family about the change that may be coming up and help them process with the patient about the outcome of the decision, depending on what the assessment says. After each intervention provided with the patient, those findings would then be shared with the treatment team by the social worker. A collaborative effort in sharing information is going to be crucial for a successful outcome with this guy. Again, depending on how the assessment goes, going forward with interventions centered around helping the client in end of life would be key. If there are concerns of the assessment and that he may not have the capacity to make the decisions that he's making, the team would then problem solve how to treat those barriers that come up before moving forward.
Eddie again. We identified two social work theories that apply to this case. First, according to Erik Erikson's stages of psychosocial development, as an 83-year-old, Mr. Perry would be in the ego integrity versus despair stage. So his "I'm tired of fighting" statement could either be interpreted as ego integrity, in which he is accepting death without fear, or as despair based on hopelessness related to his circumstances. Also, disengagement theory could apply, in which individuals gradually disengage from society with age. Specifically, readiness for disengagement is shown through his awareness of the shortness of his life, as well as his perceptions that his life is decreasing.
This is Clifford again, talking to you about theory and ethical decision-making. Both theory and ethical decision-making continue to place high value on patient-centered care. We have shared goals between theorists and care providers alike. We don't know that theory and ethical decision-making really diverge, especially not in this scenario. We can say in this case study that ethics would dictate providing the patient with the care he wants. He requests removal of life-sustaining support, which would be the pacemaker. Theory may suggest that we provide a different level of support and explore other reasons the patient may be feeling this way. In the end, we believe that ultimately both theory and ethical decision-making converge, and they support each other in encouraging the support of patient-centered care. Collaboration, teamwork, and communication. What did we learn about each other's roles or disciplines as a result of this project? Sharing the research that each of us found in our respective disciplines enabled us to open even deeper dialogue about our thought processes as professionals. An example of which includes social work primary focus in respecting the patient's decisions and right to make their own decisions about their medical care, versus nursing shares in the patient-centered focus, but can often find themselves in the dichotomy of medicine and nursing, integrating the understandings of both into practice. How did we as a group do in terms of collaboration and teamwork and overcoming barriers? Every group member was able to exemplify mutual respect for each other and their professions. We were able to explore what may have seemed like a difference of opinion at the beginning of a conversation, only to find out we actually agreed. Just the path we took to get there was just a little different. The biggest barrier to our collaboration was distance. This includes time zone differences and work, life, scheduling differences. We were able to overcome these barriers by keeping open lines and clear communication. In discussing this case amongst our team with the different disciplines, we were able to explore and understand each other's professional thought process. We were able to share anecdotal experiences along with our didactic and collegiate experiences, which is what made working together great. I would like to say thank you for taking the time to attend our case study presentation. Please feel free to reach out to any of us with questions or concerns.